We'll get started. And I was going to give a lecture on anatomy of in the obstetrical ultrasound. So this is a lecture that I've adapted from the ISUOG basic ultrasound lecture that is available on their website. And we'll talk about the learning objectives of this lecture. After I give the lecture, I hope that you will be able to compare the differences between normal and abnormal structural fetal anomalies, and we'll go over a method to evaluate the fetus from head to toe sort of thing, so that you're able to have a systematic approach to do this. So the questions that I hope that you'll be able to answer at the end is, which abnormalities would you be able to exclude by obtaining a normal head circumference and abdominal circumference section in the second or third trimester fetus? Further, what are the differences in the appearances between a normal fetus and a fetus who has open spina bifida? And how can the abdominal circumference section be used to exclude the most common abdominal wall and GI defects? So, and then finally, what are the most typical features of a lower urinary tract obstructions on ultrasound? So, you know, when you're scanning a fetus, you are scanning the fetus as the patient and not quite the same as scanning the mother. So the anatomical planes for the fetal planes are similar to what you would have for scanning any other patient, except the fetus has a different position potentially relative to the mother's position. So this is what we call, you know, the transverse position on the fetus, right? So these are the images that we hope to achieve. So here's the head, here's the abdominal position. This is a transverse image through the abdomen again at the level of the cord insertion. So that was a transverse image, but this is a transverse image, sagittal, so coronal. So I'm sure you're already familiar with all of these. Now it's important that we orient the probe, as I mentioned, relative to the fetus. So, you know, the maternal position may be different than the fetal position, because sometimes the fetal head is down. So you have to make those adjustments relative to the fetus rather than the patient. So just a note that when you're scanning, the probe often has a little notch or a little bump on one side. That will help you orient where your probe is, because most probes on the image will have a little demarcation, sometimes an arrow, or in this case, it says E8 on it because that's the type of machine that you're using. But that arrow or demarcating mark on the image denotes where this notch or marker is on the probe. So you will always know the orientation of your probe based on where this little dot is. So take a look at that next time you're scanning someone. That will tell you exactly which orientation the probe is being placed. So here's that example. This is the anterior of the maternal abdomen, of course. So you're in a sagittal plane on the mom here. So this is the top of your probe, which is this notch right here. So this is more cephalad, and this is more caudal. So, you know, the fetus, of course, you can see is head down. So this is the position of the fetus. You're scanning the mother in this plane, and this is the image that you're getting. Okay. So again, I mentioned that notch. Okay. So you need to figure out the first time you put the probe down, which way is this fetus facing? Because this will help orient your probe, because you're trying to determine the normal fetal anatomy. So this is scanning maternal anterior is here. This is to the maternal right, maternal left, posterior. So this is a transverse image through the maternal abdomen. And so you're able to determine, okay, so when this is the fetal head now, and as I sweep through, there's the fetal head, and then we're getting into the fetal neck, and then the chest, there's the heart. And if we keep going, there's the abdomen, umbilical vein. You can see there was a quick look at the bladder. So this is the way the fetus is lying, head down, you're scanning up. And so from the level of the cervix upwards, this is how you determine fetal lie. Okay, so we'll start talking about the fetal head, and specifically the head circumference section, because that's one of the fetal biometric measurements that we would like to get. So here's a cine image of the fetal head section that we're trying to optimize. Okay, so the keys of this. So if you look at this image here, you have the midline. Right in the midline, you have the falx. It's a bright echogenic line. Then it gets interrupted here with this rectangular shaped anechoic structure, which is the cavum septum pellucidum. Okay. The next thing about this head circumference section is that it is rugby or football shaped. It's more rounded at the back and it's a little more pointed at the front. Okay. But it's smooth and it's quite oval or almost oval in shape. Okay, so there are certain anomalies that alter the shape of the fetal head. So keep an eye on this. These are your sutures here. So the skull contour is regular. You have this little suture that's denoted by the asterisk. And then you have the posterior horn of the lateral ventricle, or the atria. So you want to measure this at this point at the occipital region, and it should be less than 10 millimeters. So then you have these little slit-like anterior horns. Sometimes it's very difficult to see. They lie on each side of that CSP, and they shouldn't be dilated either. And then this is your thalamus in the midline. Okay. And this is your third ventricle sitting right within the midline as well, through the thalamus. Okay, so from this image, right, you are able to get two of the biometric measurements out of the way right away. So your biparietal diameter and your head circumference measurements you get from this image. Okay, so this is your biparietal diameter. You measure from the outside of the calvarium to the inside of the calvarium. On the opposite side, it should be at the midline right, or the middle of the head, and it should bisect the thalamus there. The head circumference, you go from the outside generally to the outside of the calvarium. Okay, so the next step is to angle your probe just a little bit. Try to keep the image of the cavum septum pellucidum in place, and then rotate the probe so that you start to see still the thalamus. You see these bumps, which are your cerebellum, and then this is your cisterna magna in behind that. This is the posterior part of the calvarium, and then this is the skin line. So this is your nuchal fold. So these are the structures that you can evaluate with the posterior fossa image. Here's the falx in the midline again. You have the thalamus that I mentioned, and the cerebellum. Okay, so this is your cisterna magna. And this is your nuchal fold, or your nuchal skin line. Okay, so this is the optimal imaging plane, because the last image wasn't quite optimal. And the reason for that is that we are not seeing that rectangular cavum septum pellucidum. So in order to get the most beautiful imaging plane to be able to measure the nuchal fold, cisterna magna, and evaluate the posterior fossa, you want to see that cavum septum pellucidum, that little rectangle in the midline, and then you are able to see the cerebellum, cisterna magna here, and then your nuchal fold. Okay, so we'll move on. The next section that we want to look at we'll skip the chest briefly. We'll talk about the abdominal circumference, because the abdominal circumference, of course, is one of the greatest contributors to estimation of fetal biometry and fetal weight. It carries heavy weighting as far as the calculation that your machine will give you through head block. So this is a sweep through the fetal abdomen. Okay, so just some of the structures that you may see, this little thing here, when we come back to it. So fetal heart here, 4 chambers. This is the spine back here, right? This right there, that's your umbilical vein as it comes down. This is your bladder. And then we're going to sweep back up, bladder, umbilical vein, gallbladder there. You see your stomach, and then your heart. Okay, this is aorta right there. Okay, so if we're looking at still image of the abdominal circumference section, you have different fetal anatomic landmarks that we're trying to achieve. Okay, I'll just draw your attention. Here's rib. This is the ossification centers of the spine, stomach here, and that's your, so ribs, aorta, and spine. Okay, this is a short length of the umbilical vein. Sometimes it makes this little curvature. Okay, your gastric bubble is on the left, or the fluid-filled stomach. The rest of the echo texture is fairly homogeneous. Most of this is liver here, and then the gallbladder is just this little hint right there, and it's the right of the umbilical vein. Okay, you shouldn't see fetal kidneys in this plane. If you see fetal kidneys, you're either angled or you're a little too low, or create caudal on the fetus. Okay, so from this plane, you can measure the abdominal circumference. It's important that when you do this, that you have a true cross-section transverse image of the fetus and not oblique or angled. So one way to look at that is that, you know, the ribs are equivalent in size on each side. You see 3 separate ossification centers in the spine, and that your umbilical vein and your stomach are in the same plane. Okay, and when you do this, you go typically from the outside to the outside and get that abdominal circumference measurement. Okay, so we want to also establish the situs of the fetus, because this is important in you know, having determining appropriate situs, because certain anomalies, including cardiac anomalies, occur more frequently when there is abnormal cardiac and abdominal situs. Okay, so you do this by establishing the transverse image of the heart, and then making sure that the stomach bubble, or fluid-filled stomach, is on the same side as the heart. So it's actually very easy to do this once you find these 2 structures in the transverse plane, and then you just sweep up and down, because they should sit very close to each other. So here's an example. Here's the left side of the fetus, left side of the fetus. So this is the same image, just still images of that. So here's the heart, beautiful 4-chamber image. And then as they sweep inferior, here is the stomach. So they are both on the same side. Here's your aorta. This is the back of the fetus. There are some ribs here. This is your ossification centers for the thoracic spine. And then inferior, we see the stomach. So these are, this is appropriate situs, or situs solitus. Okay, so so this is how you do it. You start in the chest and you sweep downwards until you find the stomach, which is on the appropriate side. Okay, so you need to establish the position of the fetus, right? So figure out, we've seen this a few times now. You scan through, quite a slow sweep. There's the umbilical vein. There's the heart, okay? So now you understand, okay, well, is this heart pointing the wrong way? Well, your probe is oriented in such a way that the heart is on this side of the image, but this is actually the left side of the fetus. And here is the sweep through. This is the bladder there. Umbilical vein right there. And then there's your stomach right there. So fetus is upside down relative to your transducer. There's the heart, umbilical vein and stomach, bladder. Okay. So we'll move back into the chest. This is where we don't do any fetal biometric measurements of the chest, but there is a very important series of images that you want to take here or evaluate. And one of the most important ones, of course, is to evaluate this 4-chamber image of the heart. There are several images of the heart that constitute a full fetal anatomic survey. The cardiac 4-chamber view is an important one of those. So what you want to see is, the size of the ventricles and the atria. You want to see that that one ventricle is not larger or smaller than the other. You also can evaluate the axis of the fetal heart. And optimally, when we evaluate the 4-chamber view of the fetal heart, we want the fetus to be between the 2 to 10 o'clock position if you were to evaluate where the anterior part of the chest is relative to your transducer. Okay, so with practice, it can be easy to obtain. Practice is the key, though. Initially, it can be very challenging because you're trying to get this very perfect image on a moving object. So, but with some practice, you don't need any special skills. You just need to know how to orient your probe, and you can essentially get it in any fetal position. Although I will say that if the fetus is spine up, so that the spine is closest to your transducer or completely on its side, it becomes more difficult because of the shadowing from the ribs or the spine. So as I said, the optimal position for seeing the fetal heart is the fetal chest being from the 10 to 2 o'clock position relative to your transducer. This single view alone, when you see it this well and it looks normal, it can rule out 60% of congenital heart disease. You require additional images to rule out more and more of those, including the outflow tract views and the 3-vessel view. But this is a very important start because this rules out the majority of congenital heart disease. So the way that you obtain this is you slide up from the abdominal circumference plane that you've already scanned to get the AC measurement, and try to get this full rib image. So that's what they mean by full rib, is that you have an elongated rib. You don't want to see too many ribs in these sections, because if you see many ribs, it means that you're too oblique on the plane of imaging and you're not truly transverse on the fetal chest. So this is your starting point. This is the normal appearance of the 4-chamber view. The right ventricle here is the most anterior ventricle and sits right next to the chest wall and below the sternum. Okay, so this is the fetal left, fetal right. This is your aorta. So right ventricle is this big guy here. This is your left atrium, and it sits right next to the aorta and is most posterior. It's the most central structure. Okay, and then this is your tricuspid valve. You can see that there's a slight offset, right, of the tricuspid. It's a little bit more apical relative to the mitral valve. This is your foramen ovale, which flaps into the left atrium. You have sometimes these little echoes of the moderator band in the right ventricle. That's a normal structure. Here's the crux. And this is your spine again. So that's your descending aorta. So let's see if we can see that on the cine image from before. Okay, so right ventricle, left atrium, right atrium. You can see if you look carefully, there's a slight offset of the tricuspid valve. It's a little bit more apical. This is your crux. You can see the flap of the foramen ovale there. You can see it flapping away, and these little, you can see that moderator band. So all of those structures you can see. Okay, let's move on. The kidneys are another important structure to evaluate. We want to make sure that they are both present, and that they're normal in echo texture and they're normal in size, and that there's no obstructive uropathy appearance to the kidneys. They lie on each side of the aorta. This is a very nice picture. This is a coronal image here at the bottom. There's the aorta and two renal arteries. So remember on Doppler, when you see red, the blood is flowing towards the transducer. When you see blue, the blood is flowing away from the transducer. So these are appropriate flow for the renal arteries of this fetus. Okay, so in the transverse section, what do the kidneys look like? Well, you want to go slightly inferior to where you take your abdominal circumference section. Okay, here's your spine. Again, the 3 ossification centers available to see. They are just lateral to the spine. And there you can see them well here, one on each side. They're posterior to the stomach. You can sort of see the stomach sitting there. They are similar in echogenicity to the liver and the bowel typically. So they're isoechoic to them, slightly hypoechoic. You can see here some of the pyramids. Okay, we like the coronal view, as I mentioned, because then you can compare their position and size. And that allows us an evaluation, if you get really good, to see that renal artery on each side. So the cortex is homogeneous. The renal pelvis is right there, and it's centrally positioned. Should be less than 5 millimeters in AP dimension. Okay. So these, when you measure AP, should be under 5 millimeters. Between 5 and 10, we call that pyelectasis, not hydronephrosis specifically. And we want to follow that up later if it's in the 2nd trimester that we're noticing. Okay, the next structure in the abdominal section is the cord insertion. Okay, so you want to slide inferior from the abdominal circumference section to the sacrum. So we've seen this several times before. There's your cord insertion site. Okay, so right there, and then you can see your umbilical vein coming in. Here's your bladder. So you want to maintain that transverse cross section as best as you can. Here's a beautiful image of the cord insert. Okay, and the cord insertion sits superior to the urinary bladder. You can see color flow there. And then of course, as you sweep inferiorly, so you just want to make sure that the cord insertion is normally positioned, that it's not dilated, that there's no masses or anything sticking out or into the cord insertion site. So then as you slide inferior to the cord insertion, you will see the bladder. This is important for 2 reasons. You're able to see the bladder. It should have a little bit of urine in it, but not overly distended, okay? Especially in the male fetus, you want to evaluate the bladder and make sure that it's not overly distended. And then you can also see the origins of the 3 vessel cords, so the 2 umbilical arteries on each side of the bladder there. Okay, so if you only see one, then you have to wonder about a 2 vessel umbilical cord. Okay, so we want to complete our fetal biometry. So we've done the head measurements, the head circumference and biparietal diameter. We've evaluated the posterior fossa. We've looked at the abdominal circumference measurement. We've looked at the 4-chamber heart. Then we have looked at the cord insertion site, umbilical vein, the 2 paired umbilical arteries to confirm that there's a 3 vessel cord. And then now we want to complete our biometry and look at the femur length. Okay, so this is, we want our transducer to be completely parallel We don't want it angled. We want this as flat as possible. And then we want to measure the ossification site. So the bright part to the end of the bright part. And that gives you your optimal femur length. And you can practice and do a few of those to get an idea of the optimal position. But you don't want to measure it at an angle because then you're not seeing those edges as well. So this is the best plane to measure the femur length of the fetus. Okay. Let's talk about amniotic fluid volume. Okay, so normal AFI, so that's 4 quadrants, is between 5 and 25. We can also just evaluate a single vertical fluid pocket, and one vertical fluid pocket, if you're doing it quickly, should be between 2 to 8 centimeters. So if you measure one fluid pocket and it's under 2 or over 8, then I would probably move on to do a 4 quadrant AFI. So here's an example. This is a single vertical fluid pocket. This is the 4 quadrant AFI. So those are your measurements. So this one here correlates with this image. So that's a 5.4 centimeters. So that's normal. And then if we do the full 4 quadrant AFI, it comes out as 18.2, which is normal. So we want to make sure that we're not including any fetal parts in any of our fluid determination. We also want to make sure that there's no parts of the fetal cord sitting in our fluid, because that will affect our AFI determination. Okay, so here's our axial anatomic plane, head, 4-chamber heart, abdominal circumference, kidneys there, cord insert, and bladder. So you can see all of these things in the axial plane. So then so now that we've talked about how to get these images and looked at some of the normals, let's look at some abnormal appearances. So all of these images, right, show you an abnormal appearance of these different fetal planes. Okay, so the skull plane here, this looks abnormal, remember. This is at the level of the ventricles. Look at this skull shape. It looks a little bit like a lemon, okay? We can look at the posterior fossa in the brain, the 4-chamber heart, the stomach and abdomen. You can see here, this is at the level of the stomach. You can see this double bubble, okay? Here's the cord insertion anomaly and the kidneys and bladder, okay? You can also evaluate for amniotic fluid, and then you can look at the different sizes and their relative size to the other structures. Okay, so let's start with the skull. Okay, this is the head circumference. Remember the shape, okay? You can see abnormalities of skull shape. These are some of the things that you can evaluate by making sure that this is normal and exclude. These are some of the things that we can talk about here. So here's dolichocephaly, okay? So basically, look at this. This is the normal. This is a dolichocephalic skull shape. Often this is related to low amniotic fluid volume. The skull just gets squashed. So you can see the biparietal diameter is quite small relative to the head circumference size, and it's elongated skull. So this is dolichocephaly. Brachycephaly is the opposite, where the skull looks much more rounded, okay? Anencephaly. This is an image of the fetus, okay? So it's hard to determine, but there's absence of the cranial vault here. But if you look at it in cross section, right? This is a sagittal image and a coronal image of that same fetus. Here are the fetal orbits, right? Here's the fetal orbits, here's the nose and the chin, and then there's no cranial vault at all. There's no brain material. Sometimes, depending on when you scan, you may still see the semblance of the fetal skull. But the hint that something is abnormal there is that beyond 13 weeks, or actually beyond 11 weeks gestational age, the calvarium will start to mineralize. So the absence of a mineralized skull beyond the 11-week mark is an indicator of possible anencephaly. You just do not have the normal cranial vault. And so the brain and the neural structures are exposed to the amniotic fluid, and that is very damaging to the neurologic structures, and often it regresses. So you will see this kind of frog-like appearance of the fetal head. So the next thing is the encephalocele, right? So you see this big cystic structure extending posterior to the skull in the posterior fossa, okay? You will often see this defect or this appearance, or you can see this appearance. Here's the thalamus and the cerebellum completely herniated out posteriorly, an abnormal skull shape there, so an encephalocele. Okay, so one of the important signs in neuroradiology or in fetal imaging is the lemon sign, and that refers to the skull shape. You can see how it appears to be like a lemon. So what do we observe here? Skull shape is abnormal. The ventricles look dilated. Remember, the posterior horn, the atria, should measure less than 10 millimeters. So these are quite dilated lateral ventricles, okay? But also the skull shape looks like that of a lemon. And the reason for that is that there's likely a neural tube defect that allows the fetal skull shape to change, and it faces the cisterna magna, which causes that appearance. Okay. Cystic hygroma, there's a multiloculated cystic structure in the nuchal region, right? So this is slightly below the level of the posterior fossa. You can see these multiloculated cystic thickening of the nuchal fold there. Here's craniosynostosis. So we're not seeing that normal skull suture that we're expecting to see. The skull shape is also abnormal here. It's not that smooth, rugby ball shaped structure that we are expecting. Okay, so here's the brain at the level of the ventricles. Remember the atrium there. You can evaluate for ventriculomegaly, as I mentioned. Holoprosencephaly is important. This is why we always need to find the CSP. So here's the ventriculomegaly. You know, the plane of measurement here is not optimal. We want to measure back here, and also we're not seeing the CSP in this image, but this is, I think that lemon sign image from before. Here's an example of holoprosencephaly, right? Here's a transverse image. You see a big central thalamus, and then you see a monoventricle here that communicates anteriorly through the midline. There's no midline falx. You don't see a CSP. This is an example of a lobar holoprosencephaly. So there's this big monoventricle there. Okay, so finding the posterior fossa and the intracranial structures, we went through this earlier. You can see something called a banana sign. You can see Vermean agenesis. Here's the banana sign, okay? So this is normal, so you can see the cerebellum. So the banana sign refers to the cerebellum. It's another sign of a neural tube defect. Here's the banana sign. The shape of that cerebellum is now more like a banana rather than these two lobes. So there's the banana, okay? Vermean agenesis. So if you remember, if you look back here, there should be a central vermis that sits right in between the two hemispheres of the cerebellum. And you can see this kind of keyhole shaped defect. And this is your cisterna magna. This is where your vermis would sit. There's an example of Vermean agenesis. Okay, then in line with our lemon sign and our banana sign in the head, we want to evaluate the fetal spine and make sure that the posterior skin line is intact and the spine is also intact all the way from the neck to the coccyx. Okay, so this is a sagittal image through the fetal spine. You can see beautiful, elongated, intact skins. and you want to evaluate the entirety of the fetal spine because you want to exclude a defect in the spine. Okay, so here's an open spina bifida or neural, what we call neural tube defect. Here's example of normal at the top and abnormal at the bottom. So beautiful skin line intact. You can see all the way down cervical, thoracic, and lumbar. Here, if you look very carefully, there is a little defect in the skin, and there's this subtle cystic structure sitting right at the level of the sacrum, okay? Another image here of the head, normal head circumference appearance, or head circumference plane appearance, CSP in the anterior head there, midline falx, ventricles are not dilated. Okay, what's wrong with this one? Well, you have this lemon appearance of the skull. The ventricles are dilated. They're over 10 millimeters, right? The third ventricle is also dilated. Here's another example, same thing. This is the posterior fossa now that we're looking at, okay? Normal cerebellum, thalamus, CSP. Thalamus, here's your cerebellum. It looks like a lemon. There's also, remember, this is your cisterna magna. There's effacement of the cisterna magna. Okay, here's another example in coronal plane of the fetal spine, complete all the way down. Here, there's a defect right at the bottom. There's a little cystic structure. So all of these is the constellation of findings that you would expect with an open neural tube defect or open spina bifida. This is the normal. So look at how these differences all combine. And so when you see a normal skull shape and cerebellum and posterior fossa, the likelihood that you have an open neural tube defect decreases. Okay, 4-chamber heart, we've seen this before. You can evaluate for all of these different anomalies just by evaluating the 4-chamber heart. So we can look for an abnormal situs. Here's the interventricular septum pointing in this direction to the left. The stomach, though, is on the right. So this is abnormal. Okay, ectopia cordis. Here's an example of the fetal heart that's sitting outside of the chest, right? Here's the fetal chest. There's also a herniated liver here. So there's the heart sitting outside of the chest cavity. A univentricle, you only see this single ventricle. You don't see that nice 4-chamber, you don't see the crux. And when you put color on it, there's just a single ventricle that's pumping blood in and out, and that's it. So you can also see AVSDs. Remember, there is an offset that the tricuspid valve is more apical than the mitral valve. In this case, it's completely flat all the way across, and there's a large AVSD in this case, right? You can see the defect right here. Okay. When you're looking at the heart, also look at the structures around it. This and also the position of the heart, and make sure that it's in the midline and pointing in one direction. You can see here that this heart is more in the right chest. And so a heart is pointing this way. So and the stomach is pointing this way. So situs is correct. However, position of the heart is abnormal. It's in the right side. So this is a dextral position of the heart. And the reason is there's something right here that is displacing the heart into the right hemithorax. And that's a large congenital diaphragmatic hernia. So here's a still image of what I'm talking about. This is the diaphragmatic hernia. There's a loss of the offset there, and the heart is being pushed to the right. Okay, let's talk about the stomach, abdominal circumference. So we can establish situs. We can, when we don't see the stomach, we can think about esophageal atresia. You get a double bubble sign, which I showed earlier, which is a duodenal atresia. So I showed this case earlier of the abnormal fetal situs with the cardiac and stomach in the wrong places, opposite. the absence of a stomach, right? So here's the beginning of the scan. 15 minutes later, it looks exactly the same. And we wait and we wait and we just don't see the stomach. And so in this case, this ended up being an esophageal atresia. That's a difficult one sometimes to diagnose. In the latter stages, depending on the atresia and if there's a communication, you may also get polyhydramnios. So you have to look at it as far as the constellation of findings and not just the absence of the stomach. Okay, double bubble sign, we gave you an image of that earlier. So stomach and then a second bubble here. So when we're scanning live through this fetus, here's what we see, dilated stomach. Okay, and then the second bubble sitting there, that's not the gallbladder. Remember, the gallbladder sits to the right of the umbilical vein, so gallbladder should be over here. This is not gallbladder. So you see a double bubble in the abdomen, and that's a duodenal atresia, which is associated with trisomy 21. Okay, so we can evaluate the cord insertion, the anterior abdominal wall. We can look for two main things, the omphalocele and the gastroschisis. There is a normal midline gut herniation in the first trimester, which should resolve. So we can see this, the ex-omphalos or the mid-gut herniation, up to about 10 weeks, but you should not see it beyond the 12-week mark. So if we see a mass extending beyond the abdominal wall, beyond the 12-week mark, that is abnormal. But you can see this as a normal structure early on. Okay, the omphalocele. So the omphalocele, the cord is abnormal. The cord insertion is abnormal. So the cord actually inserts at the apex of the defect. So it can also contain bowel and liver, and it's covered by a membrane. So that's important. So it's in the midline. Here's the cord insertion. There's this mass sitting in the abdominal wall that contains a little bit of bowel, and there's some fluid there. First is the gastroschisis, which has no membrane. The defect is typically to the right of the cord insertion, and it only contains bowel typically. And you'll see these free-floating loops of bowel in the amniotic fluid. So you'll see all of this stuff that is not umbilical and not the umbilical cord, but is actually free-floating loops of small bowel. Okay, kidney and bladder. This is the male fetus. That's kind of the only time that we are we would want to consider fetal sex is if we see an anomaly with the collecting system and we're wondering about potential posterior urethral valves. Otherwise, the fetal sex determination is not crucial to what we are looking for. So here are the things that we can see, or absence of things, the renal agenesis, the congenital hydronephrosis, and the bladder outlet obstructions, as I mentioned, in the setting of a posterior urethral valve. So remember what these look like. Here's measurements of the renal pelvis. You can see the right renal pelvis here is dilated. We don't actually have the measurement, but this is over 10 millimeters. Here's the urinary bladder, the two paired umbilical arteries on each side. Okay, so how do you tell what is obstructed with urinary tract obstruction? So it depends on the site of the obstruction, whether it's unilateral or bilateral, and the importance of correlating that with your amniotic fluid volume, because both of these things will give you an idea of where the obstruction is occurring. So if the obstruction is unilateral or bilateral, the amniotic fluid volume, if it's unilateral obstruction, amniotic fluid volume will be normal. However, if the obstruction is bilateral kidneys, or if it's low, so it's a bladder outlet, posterior urethral valve, for example, then amniotic fluid will be low. So oligo or anhydramnios, because you know, there's no urine being produced that is entering the amniotic space. So renal agenesis, here's an example. There is only one kidney right there and absence of a kidney there. Here's fetal hydronephrosis, markedly dilated renal pelvis, bilateral, okay? And what else you notice here is that there's a lack of amniotic fluid volume or amniotic fluid around this fetus, right? So bilateral obstruction. Here's a bladder outlet obstruction. Dolichocephaly, right? There's no room around the head, no amniotic fluid, head is squashed. Dilated bladder with a second bubble anterior, right there, which comes to a taper. So in this case, I would really want to know if this is a male fetus. You really wonder about a posterior urethral valve in this case. Massively distended bladder, okay? Low amniotic fluid volume, okay? So we can talk about amniotic fluid. There are many causes of oligo and polyhydramnios. Oligohydramniosis is your differential, PROM, GU abnormalities, uteroplacental insufficiency, or post-dates pregnancies. Polyhydramnios has more causes, including just diabetes, isoimmunization, fetal anomalies, fetal infection, in the setting of a twin-twin transfusion syndrome for twins, or it could be idiopathic. So let's look at the different fetal sizes, or not fetal sizes, but the structures of the fetus if we scan through and we don't change the settings on our machine, okay? So this is the size of what the head would look like if you want to just look at that. The abdomen is a little bit smaller. So if you look at it, that's the relative size of the abdominal circumference compared to the head. And this is the femur length. So, all right, so key points. So we need to try to understand what normal looks like. And to do so, you know, we can use the transverse plane of imaging to evaluate the fetal structures in detail. So be consistent and try to scan things in order as you see them, so that you have a consistent approach and systematic approach. Then figure out what the long axis of the fetus is. Where does the head lie relative to the abdomen, relative to the bladder, and then you can scan the fetus in the appropriate planes based on those where you make that mental image of where the fetus is sitting. Okay, so then you assess the fetal head, check the skull, intracranial anatomy, head circumference, and biparietal diameter. Then you can slide through the chest to the abdomen, okay? You can assess the situs quickly because you can see where the heart is relative to the stomach. And then you look at the upper abdomen, measure the abdominal circumference, and then you keep going down, measure the femur length, and then as you scan through the abdomen, check the abdominal wall, cord insertion, kidneys, bladder, and then evaluate the spine and skin. Okay? So if you have additional questions, I would be happy to answer those.
Yes. Hello?
Hi.
Yes. Thank you so much for the presentation. It was an opening for me. So at what age do we really pick up most of those abnormalities? Or no organogenesis in maybe in the first 1 to 2 months? And
No. So when we do a series of obstetrical ultrasounds
Okay.
So we initially start with a first trimester ultrasound just to establish fetal dating. Okay, so ideally we do that early, so somewhere between 7 to 12, 13 weeks. To evaluate fetal anatomy, we do a detailed anatomic scan. So when I describe all of what we're talking about here, typically we try to do that at 18 to 20 weeks gestational age, because then the fetus has grown to a size that it makes it more amenable to scanning these things. But it's not so large that it encompasses so much of the uterus and it doesn't move that we can't evaluate some of the structures because of the way the fetus is lying. So as the fetus gets bigger into the third trimester, it gets harder and harder to see all of those structures. So the ideal time is, I mean, you can see some of these structures even early as 13 weeks, but typically the detailed anatomic scan is done at 18 to 20 weeks.
Okay. Okay.
That's a good question.
Prof, so were you sending those to us, because it's so important to me?
Yes, I think the lecture will be like the others. It'll be recorded so that you can review it at your free time. Yeah.
Thank you so much.
You're welcome. And you know, I mentioned the fetal biometry. Most ultrasound machines have a calculation package that you can pull up, and it will automatically, fill in the fetal biometry and fetal age. And the more you add, the more it will give you the composite measurements. So if you start with the head circumference and biparietal diameter, and then you add the abdominal circumference, it will continue to improve or add to its composite measurements. So use those calculator packages.
All right.
And yeah, I believe these may already be available, but I'll forward these or share the link so that you guys can review the slides individually as well, without going through them.
Okay.
Yeah. Mm-hmm. Okay.
Yeah.
I don't know if we have any other questions, but I hope that was helpful. You can always contact me if you have additional questions or any additional thoughts, or if you wanted me to go over something in more detail. We can certainly have that discussion too. So I'm totally available. And as I mentioned, I'll forward these slides so that you have them available in addition to the recording, so that you can look at them at your convenience.
Thank you so much.
Thank you very much. Thank you very much.